who is a So Aarti is a consultant pediatrician, right? Dr. Maddie is a internal medicine, Dr. Ankit, Dr. Shikha, and we have a nice team of doctors with Dr. Mariam Sonal and Dr. Islam. She is a neurophysician, emergency physician, surgeon. So this is an excellent team of doctors, right? We have excellent hard copy book as well. Those who are interested and fond of reading the books, this is one of the best, right? So it's available. We have excellent discounted offers for coachings as well, and data flow services, as I told you. Another important thing is we do have a lots of mock test on our website, right? And we have lots of modules of the mock test. So I strongly recommend you go for the mock test. And good news is that we are launching the dental this DHA program very soon. So those who are interested, just pass on this message to your colleague. And these are the various discounted packages. Later on, we can discuss in detail. But one of the best is a 350 package where you get everything under one roof, right? So you get, all the things. It's supposed to be 900 to 1000, but with the discount, it's 350 with the coachings and all. This all things included in this package, including hard copy book, ebook, one subscription of 3 months, WhatsApp subscription, mock test, video library, the weekly live mock test, what we are doing, mobile application, past recorded videos, and lot more. And last but not the least, those who are new joining first time, we have excellent YouTube channel on the name of Medical MCQ for All. Good amount of subscriber, and we have excellent videos keep uploading every day, right? So we have a mobile application on Android phone, right? So you can download from the store, and we have on the Apple as well. So whole website can be accessed from the mobile as well on the fingertips. It's like a mobile application of WhatsApp the same way. Just you need to download the mobile application of Medical MCQ for All, and that's it. Whole website you can access, and there are lots of modules on the as well. Last but not the least, I this is the first time everyone seeing this slide. Concentrate on this one slide. I was researching for many years and I found and I thought let me share this with you. There are lots of doctors asking me why we cannot crack the exam. So I evaluated few points, right? Why we cannot crack the exam. Any exam, forget about DHA or anything. Any Gulf Pro Metric exam, I concluded this few reasons. Probably it's more than that, but these are the key features. Probably it would be applicable to each and every one. Probably one factor, two factor, three factors, or more. So just listen it, concentrate it well. We don't need to prepare haphazard from now onwards. What we are doing the preparation at our comfort zone. So first and foremost, the extremely important what I evaluated over period of 10 to 12 years of coaching for this Prometric, unauthenticate study material. Unauthenticate study material or lack of study material, good study material is the biggest reason. The biggest reason is you won't have the proper material, unfortunately. And we rely on the free online materials, right? So, obviously, anybody can get tempted to the free materials. But honestly speaking, this online free material, various social media, Facebook, Instagram, right? And there are a lot more, right, where you probably do not get the answer of that material. You have no reference to that material. You probably don't have much pictures, ECGs, X-ray, smear, and detailed explanation, right? And there is no mock test, regular mock test, right, on the free materials as well. So mock test is extremely important, that we'll discuss very quickly. We are not doing any self assessment, right? You are preparing yourself, but you don't know where are you standing exactly, end of the day, end of the week, end of the month, and before the exam. So we are not assessing ourselves, right? So say for example we need 60 to 65% passing score, but we never given mock test to get the idea, okay, what is the score before going to the exam. We are just reading. So I strongly recommend you must go for the mock test. And another thing what I came across, we are not going to strengthen the weaker areas or subject. So what is the weaker areas? Like legal and ethics, psychiatry, some people have gynec, some people have pediatrics, some people have surgery, some people have this emergency medicine. Some people have this cardiology. So we are not concentrating on the weaker area. So this slide, I strongly recommend you take a picture. You take a picture, right? Because it is extremely important points. I try to gather over a period of 10 years of my experience concluded in one slide. So whatever applicable, I'm not trying here to demoralize you. I'm not trying to here, but I would like to show you the mirror image. Where are you standing or what you exactly need to do from now onwards, right? So this is one of the most important things, right? And over a period of time, we came across lots of MCQ. There is a scope of improvement, but our website, I'm sincerely working. There are lots of doctors joining me for more than years or as well. So it's a result of this. We try our level best to make this material one of the most authentic globally to provide the material. There is a scope of improvement. Yes, never, right? Improvement is lifelong, but we are trying, our team whole trying to level base to provide you the most authentic material. Second thing is we have no mentor, right? So who can guide you properly from day one, right? Regarding exam, preparation, syllabus, pattern, right? So because of no mentor, right, we are in comfort zone. So this is one of the horrible zone that is called comfort zone. So we are in our own comfort zone, right? We have time, we will do it later. What's the urgent, blah blah, right? So if you have no mentor, means nobody's watching you, nobody's watching you, nobody's asking you, nobody is taking interest in you because you are preparing by your own. So you need a mentor like our team, right? So feel free to contact us, we will guide you. Lack of time management, I have seen there are lots of doctors struggling to get time because they are practicing, right? They are doing job, they are doing practice in the hospital. So it's very difficult to manage a time. So whatever the time you have, you must need to prepare from day one of your exam preparation. Time management is extremely important, right? During the preparation in the exam hall as well, because I've seen many doctors who said, sir, I left 20 questions, 30 questions, questions were lengthy, I could not able to manage the time. Unfortunately, end up with the failure. So we don't need to hear the failure, right? So extremely important from day one, you manage time. Another time, again, time for time management, you need to have timetable. Like in school we are making timetable for our kids, same way we need to make it for ourselves. We are going to do the random preparation without planning, we do the preparation, we don't have any timetable, right? So today only make this all key points are the extremely important key to success, right? You are brilliant, we are a doctors, right? But if you do this fine adjustment of this one slide, your most of the problem is solved within a 1 week, believe me. I did it for myself and I cracked many exams, right? So timetable is extremely important. Some say, for example, you are working 9 to 5, so you need to do at least 50 MCQ before 9, and after 5 or 6 you get a little relax. After 6 you need to do 50 MCQ. This must be your timetable. I'm giving you general idea, you decide, you knows better than me, right? At what time you free, but you need to have some goal, you need to have some target, you need to have perfect timetable, right? So this is again a very important things. Another next point is taking premature exam is another very bad factor for failing the exam, right? Because people think, oh, I have 15 days, I will crack, right? I will prepare. I'm not trying here to get you down, but I'm giving you the real pictures, real scenarios. I coach more than thousands of doctors so far, so I'm giving you the idea, or I'm giving you the crux of my whole experience here. So you need at least 3 months of preparation for non-full timer. Non-full timer means those who are doing 9 to 5 or 6 8 hours a job every day, they are not a full timer. So non full timer, you need at least 3 months of time to prepare well, and those who are full timer, you need at least half time, means 3 months to 1.5, 1.5 months to 2 months, right? Absolutely important, because you can't take this exam lightly now. They are getting tougher and tougher, and increasing the complexity of the exams, right? And again, there is another very important reason, not in touch with clinic or academics. So I have know many doctors, especially the female, they become married and pregnant and shifted to somewhere. So they are away from clinic, they are away from academics. right? So that could be the reason, and then you give the exam without proper preparation, you get failed. We don't need to get failed, right? And that is why the joining live online coaching is one of the best tool I can assess, and that you give me the feedback after the lecture, especially the new ones. Older people knows how is the quality of the lecture, but this is extremely important point. I know many doctors, those who are out of touch, out of practice for 5 years or more, right? And now they are preparing. So you lost the confidence, right? Right? Extremely important being in the comfort zone. So get out of the comfort zone, try to push yourself a bit hard. There is no substitute of hard work. So hard work is extremely important. Extremely. There is no substitute. There is no shortcut to pass this exam. Believe me. If somebody is saying, then it is a don't take it otherwise, but it's a fraud. Without preparation, it's impossible. If you prepare well, I guarantee you crack exam in first go. Forget about second trial. I can guarantee you, first go, you 100% pass the exam. But you need to prepare yourself. You need to come and get out of your comfort zone. Excusitis is extremely another major, I think, disease in everybody's. Excusitis or excuses. I just add this itis, right? So excuse, we have a lot of excuses. We are giving lots of reason for not preparing well for exam. I don't have time, right? I'm hectic duty, I have this. Let me tell you, I know thousands of doctors who, those who are practicing, they are doing 6 hours, 8 hours, 10 hours, even 12 hours. They are pushing themselves hard and trying to crack the exam, and they crack exam in first go, right? Because they have the dream, they have the vision, they have some self confidence. So you need to improve that, right? So don't stop doing the excuses for not preparing well for exam, right? Everybody has a 24 hours. I also have excuse of not taking the class on the Sunday, but I'm taking for many years without failure at no cost. That is commitment. Overconfident and underconfident. So don't go with overconfident. Oh, I knows everything. I mean, nothing to worry. I crack NEET exam. I crack this, blah blah. Right? I know the people who crack the USMLE, but they can't crack DH, unfortunately. Right? So don't be overconfident. Confident is good. Absolutely, you should be a confident, but not over or under confident. Right? And last but not the least, where the story starts, lack of dream for yourself and for your family for better quality of life. So if you have no dream, you probably cannot reach to anywhere. You need to have clear cut dream in your mind, what you want to do, where you want to go, what lifestyle you want to live. It's all about the dream, right? So dreamers are not quitters and quitters are not dreamer. So that's it. This is what the new slide I added as a part of my experience, so you can give the later on feedback on this point, 1 to 11 later on after my class. So let's start with our main crux of the exam. So keep these things absolutely in mind. This is absolutely very high yield, right? My purpose is not to just get you down, but I want to give you the real picture, right? So whatever the point is applicable to you, just concentrate it and try to improve that. So I want everyone to pass the exam. So that's all. Let's start with the main crux, the number one questions. 65-year-old Caucasian male with past medical history of Paget disease present with 3 months of progressive worsening of lower back and hip pain. On examination, there is a large tender mass in one of his leg. Lab shows elevated ALP, that is alkaline phosphatase, ESR, erythrocyte sedimentation rate, and LDH, lactate dehydrogenase enzyme. On imaging, pelvic X-ray shows a sunburst pattern in Codman's triangle. What is the diagnosis? Is it osteosarcoma? Is it Ewing sarcoma? It is chondrosarcoma? Is it liposarcoma? Is it Paget's disease? Is it vitamin D overdose? Take your time, see the picture, don't get hurry and try to think. You have a 30 seconds, right, in your exams to think over it. So think without jumping. And another tips, while you are thinking of the answer, never ever jump to the answer without reading complete clear cut MCQ. You need to make one impression in your mind before answering anything, right? And without seeing the answer or options, you must create one impression. Forget about options. You need to create one impression in your mind that, okay, fine, this gonna be the answer. And this is how you expertise yourself. Yes, so you can post your answer in the chat box. What do you think? What's your answer? Then we'll do the real discussion of each and every MCQ today. Yeah, you can post your answer. You have a facility to post your answer in the chat, bottom of your this Zoom things. You can post your answer. Yeah, so yes, Dr. Nisha. So what do you think it could be the answer? Now let's discuss.
Sir,
Yes.
Codman's triangle usually seen in osteosarcoma.
Okay, so what is the I mean Codman's triangle? Where you see the Codman's triangle basically? On the
Uh,
radiology finding, Codman's triangle is
Relatively seen.
radiologically or anatomical finding or what?
Radiological science, sir, is a aggressive
Okay,
bond.
fair enough. So this is a radiological finding. Here we are not to mug up the answer. Here we are absolutely concept based. So in one question, I solve at least 10 questions. So once we finish one question means we crack the 10 questions. So we are going in that way next 1.5 hour. So osteosarcoma, you mean to say that there is a Codman's triangle, right? And sunburst appearance, right? So can you see the sunburst appearance on this imaging? Yes or no?
Yes, sir.
Yes, Dr. Nisha. Yeah. Can you see the sunburst appearance here? Right. So this is a X-ray, right? So this is kind of sunburst appearance. What appearance you can see in Ewing sarcoma? Second question. What appearance on the X-ray what appearance you can see on the X-ray, Dr. Nisha? Osteosarcoma, let's say X-ray is a sunburst. This all question in exam, huh? So don't take it lightly. Just concentrate. Each and every point is important. So sunburst appearance is there on the osteosarcoma. Anybody? Ewing sarcoma. What you see
Sir,
in the
light
Ewing sarcoma?
lesions.
Sorry.
Light
Yes. So
lesions.
excellent. So somebody, Dr. Aisha, posted that it is a swing or onion peel appearance. So absolutely, it's a onion peel appearance. Wonderful, right? So now these are the two things. Now third thing, what you can see in the Paget disease. Paget disease. Paget disease. Now there are hundreds of questions. Let me clarify for you guys, right? So what you can see, calcium, phosphorus, alkaline phosphate, right? Let me ask osteoporosis. Condition is osteoporosis. What happens to all these three? Open for all. If you have patients of osteoporosis, what happens to calcium, phosphorus, and alkaline phosphate? Right? Option is A, all increase, all decrease, all normal. This is increased, and this both are normal. This increase and this both are normal. So what it could be when you have a osteoporosis patient, elderly female or male, 75 years of age, diagnosed as osteoporosis, right? Then what could be the calcium, phosphorus, and alkaline phosphate? No one. It's a very easy questions. It's a very easy questions. Dr. Sidra, any comment? So yes, Dr. Aisha, any comment?
Yes, alkaline phosphate, it's normal in osteoporosis, sir. Whereas calcium is usually deficient. It's normal or mostly it is deficient. And phosphate is also mostly normal. I mean, normal or deficient. Main thing is vitamin D will be less in osteoporosis.
Okay. So, so basically, okay, fine. So this is one question. Everyone write down, huh? Everyone write down the homework, right? One is osteoporosis. Second question is bone mats. If somebody with the bone mats, if patient has a CA brace with bone metastasis, what happens to all these three? What happens to all these three? Calcium, phosphorus, alkaline phosphate. These all are high yield question in exam. They may ask you in different way, but I'm giving you the general idea so you can think that it is the one of the questions. Yes, Dr. Anjana, any comment on this? Dr. Anjana, what happens to the bone metastasis? Right? Some say, for example, patient has a breast cancer and now it's mats to the multiple bones in the sternum, in the ribs, in the pelvis, in the spine. Now, how the bone metastasis patient may present with calcium, phosphorus, and alkaline phosphate? Any idea? How the
Sir, I think
Paget disease?
calcium
Alkaline
definitely
phosphate
goes down in bone mets.
is normal.
Sorry, one by one. Sorry. Yes, Anjana, go ahead.
Yeah, the calcium definitely goes down in bone mets and phosphate and
Goes
alkaline
down,
phosphatase. Yeah, calcium
goes down, or goes up?
goes down and
In metastasis, sir, calcium is
mm,
highly increased
high. Okay, okay.
because of
Bone
the
mets.
lesions. The bone gets decomposed and calcium gets
Fair enough.
highly increased, which
Fair enough.
causes
We'll discuss
metastatic.
all the things in 1 minute. Don't worry. I'm just trying to make you understand, right? I'm trying to activate your neurons so you can think. So bone metastasis, right? Paget disease,
Paget is alkaline phosphate increase and calcium is normal.
calcium is normal. Osteomalacia, osteomalacia.
It's vitamin D deficiency in adults, so calcium will be decreased.
Mm-hmm.
Phosphorus will actually be increased, sir, because parathyroid hormone will get activated. So phosphorus will also decrease.
Fair enough. So probably I think you guys have little confusion in your mind, isn't it? Yes or no? Right? So this is one question, write down. This is one of the biggest questions where everybody gets confused. We'll discuss all the things in next 1 minute, so all picture would be clear. So let's come to the question. This answer for this question is a osteosarcoma, right? So how do you differentiate between osteosarcoma and Ewing sarcoma? Anybody has any idea? Anybody has an idea how you differentiate from osteosarcoma to Ewing sarcoma? Lots of question with this. Head to head comparison. Osteosarcoma, Ewing sarcoma. Say for example, site of the disease, age of the patient, X-ray finding of the patients, treatment of the patient, right? Any idea? What is the commonest site in osteosarcoma? What is commonest site in Ewing sarcoma? What is the commonest age presentation of the osteosarcoma, Ewing sarcoma, X-ray finding, treatment? Anyone would like to try?
Sir, osteosarcoma normally metaphysis, whereas Ewing sarcoma is diaphysis of long bones.
Excellent, excellent, super excellent. So this is a diaphysis. Oh, sorry, this is diaphysis and this is metaphysis. I will show you. Probably we forget what is metaphysis and what is diaphysis. So I will clarify. Don't worry. Right. So these all are the questions you must keep in your mind. Right. So I will go with the answers and explanations. So this is the Codman's triangle. So you can see here the picture is classical Codman's triangle. So this is a triangle, Codman's triangle. Triangle periosteal elevation seen in a various bone lesion, including osteosarcoma, is one of the most common is the osteosarcoma. So this is number one. Now let's get back to little anatomy. You probably knows, you probably forget, I don't know, but still my duty to give you the concept rather than mugging up the things. So this is a routine pictures of bone, right? As you know what is bone, so this is bone. Epiphysis is this part. Epiphysis from this to this part is epiphysis. This is this is I can write down epiphysis. I can write down this is metaphysis, and this whole up to metaphysis again. It is all diaphysis. This is diaphysis. So epiphysis, metaphysis, diaphysis. That's it. So this is what the generally I took a femur just to get you understand where is epiphysis, where is metaphysis, diabetes. Now let's go to the head-to-head comparison of osteosarcoma, Ewing sarcoma. Because I posted here osteosarcoma, but it's not mandatory. They ask what the way I teach you. They can ask Ewing sarcoma. So I compile all the things. So in one question we discuss the 10 questions. So first of all, osteosarcoma, right? It is one of the most commonest bone malignant tumor. Primary adolescence, primary age is adolescence, right? Let's finish first osteosarcoma, right? Primary and secondary elderly individual, but commonly in the pediatric age group. We have many patients, those who have a knee pain, right? Why knee pain, right? Because as I told you, they present usually in the metaphysis, right? So metaphysis of the long bone, right? So somewhere here, right? So either if it is femur here, if it is knee in the knee joint, right? Sunburst appearance in osteoporosis, Codman triangles, and mouth eaten appearance. Three things, anything they can give you in the exam. Sunburst appearance, Codman's triangle, mouth eaten appearance, right? Treatment is what? The surgery and chemotherapy, right? There is no much radiotherapy role because it is a radio resistant disease. 5 year overall survival rate. If you completely treat the patient, 70% of the patients will live beyond the 5 years. So prognosis is overall good, right? So 70%. So 7 out of 10 will live more than 5 years once you completely finish the treatment. So this is the one thing. So this is primarily seen in the adolescent. It is main site of the disease is a metaphysis. Radiologically, three findings: sunburst, Codman, and mouth eaten. Treatment probably they not ask you at the GP level, but just for your knowledge, surgery and chemotherapy. And this is survival. Ewing sarcoma, again, it is more in a younger patient, children more, right? And less in the adolescents. Diaphysis of the bone. This is the difference. Diaphysis. This is diaphysis, not the metaphysis, right? Osteosarcoma is the metaphysis, diaphysis, Ewing sarcoma, for your knowledge, right? So diaphysis, right? Onion, as Dr. Aisha told very well, onion skin appearance you can see. Again here, the difference is that surgery with the chemotherapy, you can give the radiotherapy, which is not the treatment options here. It is a radiosensitive. Osteosarcoma is not radiosensitive. Prognosis is overall good. If you treat well this type of patients, the overall prognosis is quite good, right? So this is extremely important high yield points for you to understand for exam point of view. So you need to know this slide very well. What is epiphysis, metaphysis, diabetes, diaphysis, and what is the age, site. If you know this, then your job is now easy, right? So you must know the age, you must know the site, and you must know the radiological finding. This is mandatory for you to know in the exam. And this is again a very important picture I come across while researching for my this class. So now again you see, right? So osteosarcoma, right? So osteosarcoma is usual in this part, osteosarcoma, right? It is a metaphysis. This is the diaphysis. So Ewing sarcoma, long bone in the center of the shaft of the femur, that is diaphysis. Up part is epiphysis, then metaphysis, then diaphysis. So it's in the diaphysis. This is the diaphysis, right? So Ewing sarcoma. Metastasis can be anywhere, but common site is a spine and pelvis is the commonest site, right? And chondrosarcoma at the cartilage area. So these are the few important this point where you're gonna get these things, right? So you must keep in mind, right? So sight will help you to diagnose the things. And this is super brilliant chat. I got it for you guys. So all questions will be answered in one slide. Somebody was confused between osteoporosis. So osteoporosis usually all three normal. Remember in that way, right? Osteoporosis is age induced, right? At the age postmenopausal woman and after 55 in male, osteoporosis is bound to happen. It's a physiological things, right? Right. But this osteoporosis make bone small, brittle because the matrix in the bone gets weakened, right? How did you diagnose osteoporosis? Is there any test? Which one is the best test to diagnose osteoporosis? Any name of the test?
DEXA
Any?
scan.
Excellent. DEXA scan. So DEXA scan, we know the T score, right? T score less than, right? One 1.5 to 2.5 and less than 2.5. This is how the score is done. So if you don't know what is a DEXA scan, you go and read the DEXA scan. Osteoporosis, lots of question come for the osteoporosis. So osteoporosis usually you find, even let me tell you, ESR is normal in osteoporosis. ESR is also normal in osteoporosis. It's a aging process, right? Right. This is one thing. Second thing need to remember, easier one is bone metastasis. Here all normal, here almost all increase, right? Calcium increase. Why calcium increase? Because when there is a metastasis to bone, right? So when there is a metastasis to bone, what happens? The Because of bone metastasis, right? It will erode the bone. It will release the calcium from bone to blood, right? And that is why it increase the level of calcium in the serum or the plasma and hypercalcemia. So hypercalcemia, whenever you see any patients of hypercalcemia, elderly patients, never ever miss the malignancy, never ever miss the underlying bone metastasis, right? It could be increasing other conditions as well. Myeloma, again, it's a plasma cell dysplasia or it's a bone marrow cancer, right? So this is the here all normal, almost here all increase. So two conditions are very easy. Paget disease, it's very common. They ask in the exam, Paget alkaline phosphatase is increased. That's it. Alkaline phosphatase is increased. Alkaline phosphatase is increased, right? Osteomalacia, calcium and phosphorus decrease, but the alkaline phosphatase is increased. So when there is an alkaline phosphate increase, you think of two things common: Paget disease, osteoporosis, bone metastasis, right? These are the common condition where you can see the alkaline phosphate increase. Multiple myeloma, very easy. Multiple myeloma, hypercalcemia. There are CREB symptoms: calcium, renal, anemia, and bone. So calcium is hypercalcemia, renal, uremia, or high creatinine, anemia, bone lesion, bone fracture, right? So this is how the calcium will increase in myeloma, right? Phosphorus can also increase, but alkaline phosphatase is normal. So these all are the high yield point that you must keep in mind. Renal failure, again, there are lots of renal failure across the globe. So when there is a renal failure, right, obviously the calcium is low, right? Phosphorus is high, and alkaline phosphate is usually normal, but it could be high. How come the calcium will reduce in the renal failure? What's the mechanism? A renal failure. When you have a renal failure, why the calcium is reduced?
Sir, for the vitamin D synthesis, renal is required, the last step. So if there is no vitamin D, the calcium will be decreased because calcium will not be absorbed if there is no vitamin D.
Okay, so say for example, some patient has a renal failure, but vitamin D is normal. What it could be? Calcium. What happens to calcium? Renal failure with normal vitamin D.
It is not getting reabsorbed in the body by the kidneys.
Okay. So what happens then?
It comes out in the urine and stones can form.
Okay. So you mean to say calcium, vitamin D is required to get the absorb the calcium.
Yes, sir.
Fine, fair enough. Now these are the another condition, primary hyperparathyroidism. Primary hyperparathyroidism. So let me draw. This is a thyroid gland, and behind thyroid there are two pairs of parathyroid. Total number four, two pairs of parathyroid. So primary means something wrong in the parathyroid, right? So primary hyperparathyroidism, commonest is a parathyroid adenoma. So this is condition in which there is a tumor in the parathyroid gland that is called parathyroid adenoma, right? Or there may be a parathyroid carcinoma as well. But whatever the condition, right? Primary hyperthyroidism, parathyroidism means parathyroidism, there is a tumor, right? Because of that, there is a hormone called as the growth hormone, PTH, growth hormone. The main function of the growth hormone is to, right, increase the calcium, right? So whenever there is a hypocalcemia, either you give this calcium gluconate for the treatment as well as you give the growth hormone. We give the growth hormone, right? So, right, hypocalcemia because you want to increase the calcium, and primary hyperparathyroidism or the condition where you want to increase the condition, you give some parathyroid analog, right? So there is an injection, there is a nasal spray available, right? So increase parathormone, increase calcium in the blood, right? So it increases the calcium, right? Phosphorus is reduced, right? Usually the alkaline phosphatase is normal, right? And the reverse the thing is, right? When there is a hypoparathyroidism, reverse the thing is. So you need to know each and every condition. They can ask any condition. This is very simple chart, very self-explained chart. So you can take a picture or you get hold the this video recording after the class, right? So this is very important. We usually try to avoid this topic, right? But it's very important, right? They may ask you long scenario, but the basic is this. If you remember this slide, maybe you can answer hundreds of questions, but you need to do little practice. You need to understand the logic and concept. So go and read the vitamin D calcium chapter. Go and read. Your homework is to read primary, secondary, and tertiary hyperparathyroidism, primary, secondary, and tertiary hypoparathyroidism, and renal failure. Absolutely, two questions will come from this only. Even everything is question. Osteoporosis in its own, it's a different question. Osteomalacia, Paget, myeloma, it's all high yield, right? So it's extremely important. So this is the first questions we are ending up with this. So basically in osteosarcoma, alkaline phosphate, ESR, and LDH all will increase, right? You get a sunburst appearance, you get a Codman trans, you get a mouth eaten appearance, and onion peel is seen in the Ewing sarcoma, right? So let's switch your gear from the ortho to now little hematology, and all questions you need to apply your mind very well, and end of the day you check your score how much you got it, right, out of the 7 10 questions. So first, those who did not answer, right, the osteosarcoma, your score is 0. Don't take it otherwise. Just try to evaluate yourself. You don't need to show your results to me, but you need to understand where I am standing, right, or what, how much hard you have to push yourself, right? That's it. So this is first question. Let's move to the next question. Glanzmann's thrombasthenia and Bernard-Scholier syndrome. All true except means one is not true. Both disorder present with a platelet type bleeding, epistaxis, menorrhagia, gingival bleeding with a normal platelet count. Both have a normal von Willebrand factor level. Both are diagnosed with the platelet studies. Both have a giant platelet. Glanzmann has 2B and 3A defect. Bernard Scholier has a 1B and 9 defect. All of the above is true. Everything is there in both. Post your answer in the chat box. Recently asked question in exam. Yes, post your answer in the chat box. We are more than 30 doctors now, but answer is only one. Think if this question comes to your exam, how you gonna respond to this question? Yes, Dr. Anjana, Dr. Lalit, Dr. Sidra, Dilakshi, Nisha. Yes, answer. Santosh. Yes, Dr. Anantraj. Would you like to comment on this? Dr. Anantraj. Dr. Sidra.
Good afternoon, sir.
Very good afternoon. Yes, your answer is E. So Glanzman says 2B and 3A defect. Is it true or false?
Sir, all of above is not true. Sir, that's why I go for this answer E. All of above is not true, so it's a wrong answer. Because, sir, they both have giant platelets. I'll go with that. This is all answers are not true. So this is not true. That's why I go with E. All true except all of above is true. This is not true. So
Fine.
that's my
So,
understanding.
E, last E option, sorry, by mistake, it's E, but consider this E as a G, sorry. A, B, C, D, E, F, and G. This is C, sorry, typing mistake. So this is a G, sorry. Now you post your answer, sorry.
Okay.
All is correct except one.
Yes, sir.
Yes, Lalit. What's your comment?
E, sir. No, sorry, D. I mean, only the Bernard Soulier have the giant platelet, not the Glanzmann.
Very brilliant. Great. Any other comment? Any other comment? So now tell me, what is the difference between Bernard Collier and Glanzmann's head-to-head comparison? Bernard Collier, Glanzmann's thrombocythemia. What is a head-to-head comparison? Head-to-head comparison means how you differentiate one from another. I mean,
Defect, sir, to be
fine. So answer is D. Both have giant platelets, so both they don't have the giant platelet. Rest of the things are same. Let me tell you. So before that, I will give you the basic idea. There are two systems in the body which can clot the blood. One is platelet and another is a factor. One is a platelet, another is factor. In platelet, there are two clinical problems in platelet. Number problem means number is less or high, and one is a platelet function problem. Number problem means the platelet could be high, platelet could be low. Platelet is very, very high, more than 10 lakhs. We called in our hematology essential thrombocytosis or essential thrombocythemia. And low platelet we called as a thrombocytopenia. Right. So this is one of the most commonest condition which is related with the number, either high number or low number. Right. So this is number. Right. So no, here the number is less, but the function is normal. Number is less, but function is normal. And here, the biggest thing is platelet counts are more than 150,000. Means platelet numbers are normal, but still patient is bleeding because there is a functional disorder. Functional disorder. This can be diagnosed by the CBC, right? Low count or high count. Na? You check the platelet count, either low or normal or high. So CBC can diagnose this. Here CBC will not help. Why? Because platelet counts are normal, right? So you need to know the platelet functions, right? And that can be known by the platelet flow cytometry is one of the test flow cytometry is one of the test, right? By which you get to know the things, right? So this is the basic things you must keep in mind. So anytime, whenever you come across any patients, right? So what our mind is set only for the low platelet bleeding. But now onwards, keep in mind if the platelets are normal, but still patient is bleeding and factors are also normal, means PT, APTT, fibrinogen is normal, right? PT, APTT, and fibrinogen is normal. That is a factor. If you are interested, I will teach you the this clotting cascade as well. And when the platelets are normal, factors are normal, still patient is bleeding, think of platelet functions disorder. Thinks platelet functions disorder. So it's a very important. There are two main what we know: Glanzmann's thrombocythemia and Bernard-Collier syndrome. So these both are the platelet functions disorder. So let me give you the little head-to-head comparison just to get you more detailed insight idea, right? Because we probably not good in understanding this too. So I'm not talking of all the things HUS, TTP, DIC later on. Right now I'm interested in Bernard Collier and Glanzmann's thrombocythemia. So what's the pathology in both the things? Pathology, what's the problem? So both are platelet functions disorder. This and this both are platelet functions disorder, but it's a different function. So this is a endothelial cell, right? Endothelial cell. Here is the injury, this is the defect, right? So this is endothelial cell. So there are two things. One is a adhesion problem. So platelets are at the site of the injury, platelets cannot adhere well. Platelet cannot adhere well. Adhesion problem. And another is a aggregation problem. They get adhered, but they cannot aggregate well. So so when there is a adhesion problem, adhesion, first is adhesion and then aggregation. So adhesion is a Bernard-Sholey and aggregation is a Glanzmann. That's it, simple. You don't need to mug up. This is a simple endothelial cell. If the platelet cannot adhere to the endothelial wall to form a clot. It's an adhesion problem. It is a Bernard-Sholey. Once they get adhered, but one platelet will not aggregate with the another platelet due to the defect in the surface or defect in the enzyme. That we'll see it, right? So this is a simple. You don't need to mug up. You just need to remember what exactly the pathology. So if you understand pathology, you can understand the things, right? So this is a Bernard-Sholey syndrome is basically a it's a it's a adhesion problem, Bernard-Sholey adhesion problem, and Glanzmann's is the aggregation problem. I think it's clear now. What is the problem here? Deficient in the 1B and 10A receptor, deficient, right? So this answer or statement is correct. And Glanzmann's is GP2B and 3A. GP2B and 3A. Both are autosomal recessive. Both are autosomal recessive. So this is very important things. This is a pathology. One is adhesion problem, one is aggregation. Where is the defect? In Bernard-Sholey syndrome, 1B, 1X. While in the Glanzmann, it is GP2B and 3A, right? How do they present? Both the presentations are same generally because it's a platelet kind of bleeding. It's a platelet functions disorder. Both are platelet functions disorder, right? ITP is a number disorder, right? Immune thrombocytopenia. It's not a function disorder. It's a number because platelets are low. Here platelets count are usually normal. Usually normal. Here the platelet low. So you need to understand asymptomatic or presenting with a platelet kind of bleeding, petechial, purpura, epistaxis, menorrhagia, gingival bleeding, blah blah. And how is the factor bleeding? Factor bleeding like hemophilia. It's an intra joint or intra-articular or hem arthrosis. They are deep-seated bleeding like intracranial hemorrhage. They are intra-abdominal hemorrhage. They are bleeding in the joint, right? While the platelet is usually the superficial, right? Patechi, purpura, epistaxis, you can see it, right? Menorrhagia and gingival bleeding, you can see it with the naked eye, all five things, right? While intracranial, you cannot see from outside. Hemarthrosis in the joint of knee, you cannot see. So basically, factor bleedings are deep-seated bleeding, while the platelet bleedings are the superficial bleeding, right? Another is peripheral smear. This is the change here. The Bernard-Sholey have a giant platelet, and here the normal platelet. Here where the Glanzmann. So Bernard is a giant, right? It's an adhesion problem. It's a giant platelet, right? And another test is a abnormal ristosine cofactor assay. Give the name of the test. Give the name of the test, right? For Bernard-Sholey, abnormal ristosine cofactor assay. It's a diagnostic test. It's a diagnostic. Bernard-Sholey syndrome, go and read it. Abnormal ristosine cofactor assay, right? And here the normal platelet usually, right? And here PT and APTT in both Bernard-Sholey, PT and APTT normal, fibrinogen normal, all normal, D-dimer normal, fibrinogen, APDP all normal. So this is a platelet functions disorder. So this is the key point in our discussion, right? So this is how you differentiate. This is the literature from the master the board. I took it. So answer is D. Bernard-Sholey has a giant platelet while Glanzmann's thrombasthenia has a normal platelet appearance or not big, large or giant platelet. This is absolutely copy paste from Master the Ballard, Glanzmann's thrombasthenia and Bernard-Sholey. Both disorder present with the platelet type bleeding, right? I already mentioned it in the question. Both have a normal platelet count. It's a platelet functions disorder, not the number disorder. That is why normal. Both have a normal von Willebrand factor. Why normal? Because it's not a von Willebrand disease, right? It's a platelet functions disorder, right? So if you have a von Willebrand disease, then your the von Willebrand factor antigen is low, not the normal. So difference between Glanzmann's, Bernard, and von Willebrand is that Glanzmann's and Bernard has a normal von Willebrand factor, while the von Willebrand disease has a low factor of von Willebrand. And both are diagnosed with the platelet studies or flow or platelet study or flow cytometry. The distinguished feature is a Bernard-Sholey has a giant platelet while the Glanzmann's does not have. That is the answer D. Glanzmann's has a 2B, 3A defect and Bernard has a 1BX defect. That's it. So this is copy paste from the master of the board just to get you the idea. Right. So this is what the thing is. So let's get back to the questions. Now you can, I think so very easily you can now differentiate what's your answer. Right. Right. So you can differentiate what's the answer. Now see, right. So both disorder present with the platelet type of bleeding. Yes, it is correct. Both have normal 1 Willebrand factor antigen. Yes, correct. Low level is only in 1 Willebrand disease. Both are diagnosed with the platelet studies. Yes, it is correct. Both have a giant platelet. No, it's not correct. Right? Bernard Shoddy has giant platelet. Glanzmann's has normal. Glanzmann's has 2B, 3A defect. Yes, it is correct. Bernard Solier has a 1BX defect. Yes, it is correct. All of the above is true? No, not true because D is not true. Is that clear to everyone? At least tell me yes or no.
Yes,
I
yes,
am
sir.
pushing
Yes.
myself
Clear,
to
sir.
make you understand. You just need to confirm yes or no. Is that clear to everyone? Any question?
Yes.
Hello.
Sir, so answer is G or answer is D?
Answer is D, doctor. G is not the answer. No? G means all of the above is true because all of the above is not true. D, both have giant platelet. So that is a wrong statement. You understand? As we seen in
Yes,
the right, this is not a true sentence, right? All of the both have not giant platelet, na? So one has a giant platelet. Giant platelet is a Bernard-Collier syndrome has a giant platelet, right? And Glanzmann's thrombocythemia has a no giant platelet. So
normal.
this sentence is
Okay,
not
sir.
correct, right? So
Thank you
all
very
is
much,
true.
sir.
All is
Great
true
explanation.
except. So this is except. This is except. This is not true. A true, B true, C true, D true, E true. Is that clear? Yes or no?
Yes, sir. Thank you very much, sir. Thank you.
Excellent. Last but not the least, anybody wants to tell me the treatment? What is the treatment of Glanzmann's thrombasthenia and this thing? So, new doctors, those who are joining the first time, I give always the triad of MCQs, though I did not patent it, but it is a triad diagnosis, investigation, and treatment. Any MCQ now onwards you solve, you need to ask yourself three questions. What is the diagnosis here, right? What is the investigation? What is the treatment? Right? So, how you diagnose Glanzmann's and Bernard Collier, how you investigate Glanzmann's and Bernard, how you treat Glanzmann's and Bernard. That's it. So, if you ask yourself three questions, you are master. Believe me, you are master. But we are not asking to ourselves. We are just mugging up or we are just solving, but we are not concentrating. Yes, Dr. Lalit, would you like to comment on the treatment part of this Bernard Collier? If you have a patient of Bernard Collier syndrome, how you gonna treat this patient who present with the epistaxis? Fine, fair enough. So treatment
Sir,
of the both disorder is same. Desmopressin to release the subendothelial store of von Willebrand factor and factor 8A. So desmopressin is the treatment. It stops the platelet kind of bleeding in both the platelet functions disorder. Tranexamic acid, absolutely, it's antifibrinolytic. It's important. Recombinant factor 7A and estrogen also upgrade the von Willebrand factor will help to stop the bleeding as well. So this is the treatment, though may not ask, but you must know. So now your homework is to once again go and read the Bernard Collier and Glanzmann's. I tried my level best to give you the basic concept of Bernard Collier and Glanzmann's thrombasthenia. We have many things to discuss in low platelet, but probably it's a different hematology lecture. We'll take in some time. Next questions in front of your screen. Bit easy, probably you must have come across this many times in clinic. A 4-year-old child is in case brought in because of extreme irritability and refusal to eat. He refuses to lean back, speak speak is muffled words, looks extremely ill and is drooling. Chest X-ray shows positive thumbprint sign. What is the most appropriate next step in the management? So you take your own time, you intubate the patient, you give the racemic epinephrine, you give empiric antibiotic, you do physical examination or you need to do the CT scan just to diagnose the other condition. So without diagnosis of this case, you probably not manage these patients well. So you first need to make a diagnosis, you need to make an investigation, then management or treatment. So they are asking directly management or treatment, but I want you to know what it could be. What is the differential diagnosis of this patient? What this patient is suffering from?
Sir, it is epiglottitis, and we will do the intubation.
Okay. So what's the diagnosis? Exact diagnosis or likely diagnosis? Acute epiglottitis?
Yes, sir.
Sorry.
Acute epiglottitis.
Okay, this is acute epiglottitis. Okay. So acute epiglottitis, fair enough. So what point favoring the
Medical
acute
emergency.
epiglottitis?
Yeah,
I can
first
say
patient is
I'm saying this is a group
Yes,
just for
sir.
discussion point. So how you differentiate? What point favor? Last lecture I told you whatever the diagnosis you can make in your clinic or in exam, wherever, just gather what are the point in favor of your diagnosis, what are the point not favoring your diagnosis. So let's go with the acute epiglottitis. What are the point favor in the scenario? In the scenario, tell me
Sir,
at least 5-10
it's
patient
an
points.
inflammation.
drooling.
It
Patient
is
is
Drooling
drooling.
drooling.
level, sorry.
It's an
Okay, so
Drooling.
fine. So let me write down one by one. So drooling, you told drooling. So one is a drooling. Okay, what is
Used
second?
to back, extreme irritability to
extremely
refusal to eat.
It's
Extreme
thumbprint sign on
irritability.
chest X-ray.
Extreme irritability, second point. What is the third point? There are all points are in favor. I will show
Thumbprint
you
or
in
chest
next
X-ray.
one.
So
Sorry.
thumbprint sign on the X-ray.
Yes, so that is excellent. Again, important thumbprint sign, right? While in group you see the steeple sign. Group
Steeple
People.
sign.
steeple sign. Yeah. Third. So all basically, Paul, it is seen commonly in the children, right? Extremely irritability, right? Refuse to eat because he cannot swallow anything, acute epiglottitis, right? He
Sir,
cannot
even
lean
this
back. Why? Because airway
not
is
eating
compromised,
well.
so he don't want to go back, right?
Yes.
Sound is absolutely muffled. It is classical case of acute epiglottitis, right? So we get to know that, okay, fine, this is acute epiglottitis. Now tell me, acute epiglottitis is bacterial or viral? Number one question. Exam question. Which bacteria, which virus can cause acute epiglottitis in 4 years
Epiglottitis
of child?
is bacterial. Mostly Haemophilus influenza B causes it.
Okay, so it's a bacterial.
Yes, sir.
Okay, and croup is what? Bacterial, viral, or fungal?
Mostly viral, sir.
Mostly viral. Fair enough. So we at least get to know that what is viral, right? So now this patient comes to you. Now what you want to do for this patient? You diagnose this patient by history, physical examination, chest X-ray, classical signs. You diagnose, sir, this is acute epiglottitis. By the you did investigations as well. Probably counts are high, chest X-ray, thumbprint. Right now, it's a time of management. So, what you want to manage? How you want to manage? You give epinephrine, you give antibiotic because you told this is a bacterial infections, right? So, for bacterial infection, you need antibiotics. So, right, forget about this. Physical examination will not help. CT scan probably not help. So, you have three close answer. What you gonna select from this?
Sir, intubation. We will intubate.
Racemic
So you
epinephrine.
okay,
Sir,
so now you
first we need airway to be a little less inflamed. So airway dilation might help epinephrine.
No,
fine.
clearly intubation. I think intubation is the only option because air he can collapse at any time because he's
Fine.
extreme
So
irritable.
so now third option is gone. So this is interesting, na? That is why we are discussing, na? So which one is better? Intubate
Sir,
better, or which one is the life saving, or which one is like most important in the emergency room? Because this is extremely irritable, refuse to eat, patient muffles word. So this is classical signs of, I mean, acute epiglottitis. Fit case
Sir,
of acute.
intubate. Sir, it's a medical emergency in children.
Is it applicable here?
Yeah,
sir,
applicable.
intubation.
Applicable.
They did not
Yes,
mention
sir.
vitals.
Correct.
Applicable.
So in any emergency, whenever there is a airway is compromised, muffled sound, drooling, thumbprint, extremely irritable, first and foremost is to secure the airway. and secure the airways in terms of intubate the patient. Intubate the patient as soon as possible, as soon as possible, right? So that is the answer. This is a head-to-head comparison. Listen it, very important, right? Right. This is croup. Croup is like the name of the another name of the croup is laryngio tracheo bronchitis. First is epiglottis, below epiglottis is larynx, larynx trachea, and below trachea is a bronchus. So acute epiglottitis, right? And then croup, laryngeotracheobronchitis, LTB. Remember, laryngeotracheobronchitis. So epiglottitis, right? So this is kind of epiglottis, right? So this is epiglottis. So thumb print sign in epiglottitis. Here the steeple is like triangle. It's like a knife, sharp knife, right? So you can see here the building, right? This is a steeple sign, steeple. It is a sharp, it is a thumb, right? Because of the anatomical things, right? So no need to remember or mug up, right? You just need to understand. So this is a epiglottitis, H influenzae, bacterial, this is viral. Which virus? Para-influenzae and RSV, respiratory syncytial virus. It's common, right? So just remember, probably they may ask, they may not ask, but it's important. Age group is epiglottitis is commonly this. This is more commonly in the younger than the this epiglottitis. Onset is absolutely rapid. So rapid onset, rapid action. You need a. It is gradual over 5 days, 7 days, 10 days. This is a supraglottic above this is subglottic. Temperature, high grade fever, it is bacterial, this is low grade or normal. Dyspnea is severe. Why? Because the absolutely all because of inflamed epiglottis, there is nothing going into the airway. That's it. So it is a severe dyspnea patient, right? So even they cannot give the history. You need to intubate, you need to do as soon as possible. Patient may die because of airway compromise, absent or mild. So dyspnea is usually not there, right? In croup, right? So dyspnea is not there. Coughing is minimal, no larynx is involved. Here the barking cough because laryngotracheobronchitis. So cough is real airway is involved. So barking and coughing is there. Speech unable to speak, right? Here the hoarseness of voice, unable to swallow or drooling, right? And able to swallow. That's it. So this is the head-to-head comparison of croup versus acute epiglottitis. So that's it. This is another chart. I got it for you, but this is by and large the same, right? So nothing much to worry. So here, a child present with a classical sign of acute epiglottitis, the truest medical emergency in a pediatric, he must be intubated at once. Do not waste time with anything else, including all full examination, as his airway may close off any minute, any time. This case mention a thumbprint sign on chest X-ray is also suggestive. So remember your ABC, then whatever you want to do, you do it. Hope I'm clear from my side. Is that clear? Yes or no? At
Sir,
least tell me yes or no.
if the same patient comes to the clinic, so normally we will not have that much this one to do. So that time, what would be the best management, sir? If the patient
Then
comes,
to then if you have epinephrine, you give epinephrine. That's it.
okay. Epinephrine helps those patients in
Yes,
this scenario.
yes, it helps. It helps to reduce the laryngeal edema.
Thank you, sir.
Yes. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir, clear, sir.
Wonderful, wonderful. So just keep in mind this is the easy chart. Probably you must be knowing this chart, but I try my level best to make it little more easy. Right. So next questions. A 55-year-old man with the diabetes, hypertension, and a history of pneumonia treated as an outpatient 20 years earlier, present to the clinic during early fall means it's a fall season. In Western world, they called as a fall, summer, winter, rain. So fall is a season. Don't get it. It's not fall down. It's a fall season. So once again, 55-year-old man with diabetes, hypertension, and history of pneumonia treated as an outpatient 20 years earlier, present now to the clinic during the early fall season for a blood pressure checkup routine. He currently works as a respiratory therapist at a local hospital. The physician suggests that he must receive a pneumococcal vaccination. Which or what is the primary indication for this gentleman to receive the vaccine? He is 55 years of age, because of his hypertension, because of his diabetes, because he is a health worker, because he has a past history of pneumonia 20 years back. What is the strongest indication for him to take a vaccine? That's the question. Recently asked
I think,
question.
sir, he is healthcare worker. See,
Okay, healthcare
simultaneously, he has
worker.
a history of diabetes and hypertension also.
Fine, fair enough.
He is the
So
ideal
which one is the
candidate for
most
the.
deadliest? So if I remove this option, just for learning purpose and discussion purpose, if I remove this option, say for example, A, B, C, D, then what will you select?
Sir, option B, diabetes.
Okay, fair
Yes,
enough. So one
diabetes.
answer is diabetes. Let's see what another answer. Age is more important for this. Diabetes is more important. Healthcare workers, hypertension should get it. He already had a pneumonia, so he must get it. So what is the most important thing out of this five? All five important, but amongst five, what is the most strongest indication for this candidate to get a vaccine?
I think, sir, again, the respiratory therapist.
Interesting question, huh? Yes, anyone else?
Sir, I think it is diabetes only, sir, because of less immunity.
In diabetic patient, it is advised every year they should take pneumococcal vaccine.
Good. Wonderful. So it is the diabetes. Answer is diabetes. Diabetes is an indication for the vaccine given that diabetic patients are considered to be immunocompromised. Diabetic, especially poorly controlled diabetic patients, are vulnerable to infection. Chronic hyperglycemia of diabetic leads to abnormality in cell-mediated immunity and phagocytosis functions. Also, the vascular impairment of the diabetes prevent the immune system for responding appropriately to an infectious challenge. So this is one of the most important indications. So if somebody is diabetic, is good enough to go for vaccine. That's it, irrespective of anything. More risk factor, more chances. Right? What is another? Age 65. Here the age is 55. So not just 55 is recommended. 65 as per the, this all as per the guideline. So age 65 years or old is an indication for the pneumococcal vaccine, as elderly and very young are especially susceptible to this. Another explanation, C is incorrect. What is C? C is healthcare worker. So healthcare workers are recommended to receive the pneumococcal vaccine due to the exposure in working setting. However, for this patient, his immunocompromised state secondary to diabetes is more pressing reason to administer the vaccine, not just the healthcare worker. Hypertension itself is not an itself an indication for vaccine, and E is not correct. Current respiratory infection is contraindicated for the vaccine, right? So that's it. So this is what the thing is. So diabetes is considered to be the one of the most biggest risk factor for this. Let's jump to the next question. Hope I'm clear
Sir,
from my side.
sir,
Identify the great.
in the previous
Yes,
question, the history of pneumonia, because it is only once, it's not that significant, or how does it go, sir?
it's not significant because 20 years back is quite long time.
Okay, okay, sir.
Identify the grades, but irrespective, I mean, diabetes is considered to be the biggest risk factor, right? Whether it is recent or past. So whenever the diabetes in the question, right, always think of that. Identify the grade of diabetic retinopathy. You have seen a picture of ophthalmoscope. There is a picture of retina. On retina, vessels are going. They are saying that this is a AV nipping. AV means atria and venous nipping or crossing with each other. Dark is artery, light is vein, so they are crossing each other, right? In the ophthalmoscope, in retinoscope. So what kind of this diabetic retinopathy is grade 1, 2, 3, 4? And how you gonna manage this? What's the treatment of this? Post your answer. Yes, post your answer. Yes, post all, everybody. I want an answer from everybody. We are 35 doctors. Answer is 2, 3 only. Yes, Dr. Safa, what's your answer?
Sir, because AV nipping is there, mostly it is grade 2, sir.
Okay, so what is grade 1? What is grade 2? What is grade 3? What is grade 4? So
The
what you
grade,
see in grade 1, this is grade 2. What is grade 3? And what is grade 4?
the grade 1
They,
is
they- sorry. Yeah, carry on. Sorry.
grade 1 is AA, sir. It is arterial attenuation. The arteries get narrow and they become very torturous.
Okay.
And grade 2 is AV nipping will be seen. And grade 3, sir, it is more about hemorrhage, retinal hemorrhage, and the cotton wool spots and everything will be seen in grade 3.
Okay. And 4?
Grade 4 is the last, it's very severe one. It's like the optic nerve swelling and papilledema.
Wonderful. Excellent. So this is what the 1, 2, 3, 4, those who are never seen the picture. So now grade 1 is arterial thickening. First, there is a thickening. So this is normal. So there is a thickening of the arteries. This is exactly what you can see in the scope, right? Or it is called as a silver wiring. Silver wiring. The word is silver wiring. You can see like a silver wire or arterial thickening. This is a B, right? Higher the grade, bad the picture. So grade 1 is good. Grade 4 is very bad or worst. Grade 2, right, is AV nipping. A means atrial and venous crossing, AV nipping. So this is AV nipping, arteries and veins, AV nipping. Third thing is because of retinal ischemia, you get a cotton wool, looks like a cotton wool, right? Grade 3, cotton wool, right? And grade 4 is a papilledema. Grade 4 is a so it's a very bad papilledema. So we see the papillary edema or papil edema, right? So papilledema is the worst one of retinopathy. So this is how long-term hypertension, long-term diabetes may cause retinal. So it's a target or end organ damage. As we know, right? Diabetes can cause what? Right? Diabetes can cause peripheral neuropathy, nephropathy, retinopathy, stroke, right? And plus this cardiomyopathy as well in a long standing, right? So this all target organ, right? And one of them is a retina, right? So it is one of the cause of acute retinal detachment, or you may have bad diabetes uncontrolled, maybe have thrombosis, right? So first artery get thick, and then there is a AV nipping, then there is a retinal real ischemia because of diabetes, cotton wool appearance, and last but not the least, papil edema, and fourth grade 5 is blindness, right? So if you don't control the grade 1 will progress to grade 2, 4, 5. That's it. Is that clear? Yes or no? Yes or no?
Clear, sir.
Yes,
Just
sir.
keep
Yes.
this slide in the mind, though it is a very easy questions, not very tricky questions, but sometimes they ask this all various grading of retinol this thing. So we need to know what's going on.
Management, sir.
Yes, you need to tell me. So primary management is to control the diabetes. That's it. Number one, right? Second thing is there is a diabetes. Obviously, I mean diabetic retinopathy. So you keep the primary disease under control, right? And there is a two type of retinopathy: non-proliferative and proliferative. If you go bit little in detail, so non-proliferative is like something in it is little less dangerous than proliferative, can be managed with the drugs. And proliferative you need to do some laser surgery, right, to reduce the neo blood formation. Otherwise this retinal veins and arteries may damage, and or you may have cotton wool exudate or hemorrhage. You can see the number 3, retinal ischemia or blot hemorrhage and cotton wool exudate, right? So this 3 and 4 will eventually develop the retinal hemorrhage. And to prevent that, there is a photocoagulation. As per the book, photocoagulation, right? So you need to do a photocoagulation, and you need to burn the accessory arteries, otherwise they bleed. And second thing is VEGF, one injection, vascular endothelial growth factor, VEGF. that reduces the growth or proliferation of the retinal vessel. That is also given retinally. So these are the two treatment. Probably they not ask, but if they ask photocoagulation, retinal photocoagulation, as well as VEGF, VEGF, VEGF. We have a lot of questions on this on our website in ophthalmology department. So you just go and cross check it out. But this is the basic. You need to know the types of the retinopathy. Yes, last couple of questions. 32-year-old woman, right, who gave birth 4 months ago is brought in her by husband because of depressed mood. The husband reports that she has been depressed since the birth of her child, refuses to eat, has trouble sleeping, and is unable to concentrate. The woman reports that she has lost interest in the everything and sometimes cannot even get out of the bed. She has recently had a vision of seeing her deceased mother talking to her and criticizing her skill as a new mother. She also admits that she hear her voice talking to her constantly. She denies homicidal or suicidal ideation. Which of the following is the best initial treatment? So, before starting the treatment, you need to remember our triad, right? What is the triad? Diagnosis. So, what is the diagnosis? What is the investigation? And what is the treatment? They directly ask the treatment. So, before that, you need to make a diagnosis. What this lady is suffering from, then your job is easy. I'm giving you the clue.
Postpartum
Most
depression.
probably she is postpartum psychosis.
So this is a postpartum depression and postpartum psychosis. So this is depression or psychosis. How you differentiate?
I think it is psychosis because
Sir, psychosis, because we can hear
psychosis.
that she is talking and she can hear the hallucination
Hallucination.
is there. Hallucination
The
means it's
hallucinations, the
psychosis.
hallucinations, yeah.
Excellent.
Not depressed
Hallucination.
mode means
Hallucination.
depression.
So how many type of hallucination?
All senses,
Auditory,
visual,
visual,
auditory,
Well, auditory.
taste, all the
all the
five senses
senses.
hallucination.
Auditory hallucination, visual hallucination. What else?
Taste, smell,
Tactile.
Taste, smell. So actually it is not there, but they can perceive, isn't it? That is hallucination, right? So auditory hallucination means listening some voice which is not there, listening some horse voice which is not there. This is what the MCQs, right? Different, right? Visual hallucination means they can see, oh, something is coming, going, right? This is which is not there, right? He thinks that somebody is seeing me from the window, but if you go to window, there is nobody, right? Mother is talking to him. So auditory hallucination, he sometimes say, I see my mother who is already died. It's a visual hallucination. So which hallucination is most common in clinical practice? Which hallucination
Auditory.
is the most
Auditory.
common? There are a lot of hallucination: auditory, visual, taste, smell, blah blah, right? So which hallucination? Auditory hallucination is one of the most common in clinical practice. So now we get to know that this lady probably suffering from postpartum psychosis. Okay, so this postpartum psychosis, right? How you gonna treat this patient? You give psychotherapy, you give behavioral therapy, you give sertraline, you give respiridone, you give phenelzine. What will you give? What this drug is all about? Atypical or typical? Typical antipsychotic, atypical antipsychotic. Probably the last question, so bear with me. 5 more minutes.
Answer is resiperidone.
Resaperidone. Okay, fine. Let's see. Resaperidone. So what? Let me have some more answers for the discussion point of view. Anyone else want to tell me, Dr. Aisha, Jairaj, your comment? Yes, Dr. Akshay, your comment. Okay. So what is basically respiridone? Can anyone tell me what is respiridone? Which group of drug is? What is the commonest side effect of respiridone? High yield questions in exam. Psychotic drug, what is the use, what is the contraindication, and what is the side effect of the drug? This is asked in each exam. Each and every exam they ask this. Yes, anyone wants to try this? What is respiridone? Can you talk on this respiridone for 1 minute?
Sir, risperidone is atypical antipsychotic drug, sir.
Okay, so second question, doctor. How you differentiate typical from atypical?
So typical means it acts specifically on the dopamine receptors and blocks them, whereas atypical means apart from dopamine, it acts on serotonin and epinephrine and other receptors also.
Okay, so you mean to say typical dopamine, that is dopamine plus other receptor, they gets blocked, right? That is
Typical only
atypical.
dopamine, sir. Yes.
Typical
Atypical,
only dopamine, atypical dopamine plus other receptor. We'll gonna
yes.
see that which receptor. Second thing, how about the side effect profile? The typical is more toxic or atypical is more toxic? What are the
Typical,
advantage and disadvantage of typical and atypical? Both have advantage, both have disadvantage. What are the advantage, disadvantage? These all are the exam question.
typical has non-extrapyramidal symptoms, sir, whereas atypical are mostly like because of the extra receptors, like they get weight gain, cholesterol gets increased because epinephrine is activated. That's why.
Fair enough. So typical has a more of extrapyramidal side effect, while atypical has a metabolic syndrome.
Yes, sir.
So hyperglycemia,
Mhm.
dyslipidemia, obesity, it is not a drug of choice, right? Because already he is a diabetic and you are adding atypical, which worsens the diabetes, isn't it? Yes or no?
Yes, sir.
Fine, fair enough. Right. So now what is a sertraline then? Respiradone is a atypical. Then what is a sertraline?
Sertraline is SSRI, sir. It is
What is SSRI means full form?
SSRI means serotonin,
Selective serotonin reuptake inhibitor.
Selective serotonin.
selective serotonin
Wonderful.
reuptake inhibitors.
Wonderful. So this what SSRI will help? Will SSRI will help to this patient? Yes or no?
No, sir, it won't help because SSRIs are normally not used for the psychotic illness. They are used for the neurotic illnesses.
Okay, fair enough. So can you name the disease where the sertraline is the drug of choice or first line treatment? Sertraline. Few disease name. I will give you one. Major depressive disorder, drug of choice, sertraline or SSRI. Isn't it? Yes or no?
Yes, sir. Correct, sir.
Wonderful. What else? What else? One is major depressive disorder or depression.
OCD, sir, anxiety.
OCD. Wonderful. So OCD, that is obsessive compulsive disorder. That is OCD, isn't it? Fair
Yes, sir.
enough. Second, third, GAD
Anxiety
you use.
disorder.
GAD means generalized anxiety disorder.
Yes, sir.
Okay, fine.
Anxiety.
Fair enough. Where? What else? What
One more, sir. They are safe in cardiac
Traumatic,
patients.
post-traumatic.
They are safe in cardiac patients
PTSD.
also.
Okay, sertraline is a safe in cardiac patients also. So somebody has a post MI and post MI depression, and you want to start this antidepressant in a post MI phase. SSRI or sertraline is important. This is also exam question. They will give you the list of the drug. Which one of the following is the safest? Sertraline, isn't it?
Yes, sir.
Excellent. Anything else?
Premenstrual also sometimes sertraline can be given, sir, if it is premenstrual disorders.
Fair enough. So this is excellent discussion, right? So let me go to the journey of the basic thing, psychosis. What is psychosis? We know psychosis, but still I want to define it. An impaired perception of reality, characterized by delusion, hallucination, and disorganized thinking, right? Psychosis may be primary, caused by an underlying psychiatric disorder like schizophrenia, example, or secondary, caused by medical disorder or substance induced, some substance abuse. You also get a psychosis. So there could be a two, primary psychosis or secondary psychosis. Second thing is definition. So impaired perception. Perception is impaired, faulty, difficult. Impaired perception of reality, characterized by delusion, hallucination, and disorganized thinking. So this is psychosis, right? Number one. Number two, patient with both patient with both mood and psychotic symptoms respond to both antidepressant and antipsychotic. If you have mood, it's a neurotic things, all right? There is a change in the chemical, you give neurotic drug or antidepressant, and when there is a psychosis, you give antipsychotic. However, you must treat the worst symptoms first. You must treat the worst symptoms first. And in this case, antipsychotic would be the most indicated to reduce the psychotic symptoms like hallucination and all, right? So this is the worst symptoms, right? So people are saying, sir, why not sertraline? So sertraline for mood and this hallucination, psychotic symptom, you need to give psychotic. Worst one you treat the first in any patient. So here the psychotic is the worst than just depression, right? So this is the advanced psychiatric disorder. So antipsychotic would help, right? So that is the one thing. Let's go to little more literature. What is the difference between typical and atypical antipsychotic? Just to clarify the thought process in our mind to all the doctors. Typical antipsychotics tends to more strongly block dopamine. Atypical antipsychotic have greater effect on serotonin. So this is one primary. One is dopamine, typical serotonin. Both group of antipsychotics share the similar side effect, such as dry mouth, sleepiness, weight gain. But typical antipsychotic have higher risk of uncontrollable bodily movement, that is extrapyramidal system, right? Uh, and risperidone, extrapyramidal symptoms. And this is again a comparison of head-to-head comparison between first generation and second generation. Right, so first generation antipsychotic, second generation antipsychotic. First generation antipsychotic, let's clarify the thought process mechanism. Dopamine antagonist, here dopamine plus 5-HT antagonist. Number one, how it helps diminish the positive symptoms of schizophrenia, help diminish the positive and negative symptoms, right? Side effect, higher TD means tardive dyskinesia, extrapyramidal symptoms, neuroleptic malignant syndrome. So one of the side effect of antipsychotic drug is a neuroleptic malignant syndrome, NMS, right? Side effect here, side effects, lower risk of tardive dyskinesia, extrapyramidal symptoms, and neuroleptic malignant syndrome. But here the another here, right? So this is side effect, higher side effect. This is lower side effect. But the same way, right? It high this dyslipidemia, hyperglycemia, obesity is more common in this group. So those patients already have bad cholesterol, bad diabetes, and bad obesity. It is not a drug of choice because it worsens these three things, right? And this is also called as a conventional or first line or typical. This is a called as atypical, right? Antipsychotic drug. Typically blocks the D2. This is D2 plus other as well. That's it. So this is about the general understanding and what's the common example of conventional or first generation or typical. So three names: conventional antipsychotic, typical antipsychotic, same thing, right? This is atypical antipsychotic. So what are the common name what we heard so far? Haloperidol, yes, we have seen, right? Then probably prochlorpromazine, you also must be have heard, right? Then you must have heard this thioridazine, you also may have heard of this. And here aripiprazole, clozapine, olanzapine, right? Quetiapine, risperidone. So don in pine, right? So pine, clozapine, olanzapine, right? Quetiapine. So this pine and don, don, risperidone, zisparidone. So these are the atypical antipsychotic drugs. That's it. So this is how it clinically used. And last but not the least, all right, this is what the excellent chart I got it for you guys. Potential side effect of atypical antipsychotic based on the receptor profile, right? So this is the atypical. They ask you in the exam, right? So respiridone. So let's see respiridone, right? He is the here. So acute Parkinsonism, elevated prolactin, and weight gain, as I told you. So it's not good drug for the obese patient. It already obese, and you are adding the respiridone, right? Ziprasidone, prolonged QT interval. This is question recently asked in the exam. So patient with the prolonged QT syndrome, drugs to be avoided, antipsychotic drugs to be avoided is a ziprasidone. It's an atypical, right? Quitipine, potential side effect, diabetes, not good for diabetic, orthostasis, right? Sedation and weight gain. So metabolic, kind of metabolic syndrome. Metabolic syndrome, those patients, quitapine is not a good drug. Olanzapine, frequently asked in the exam, anticholinergic side effect, diabetes, hyperlipidemia, weight gain. So by and large, this is not good in general. The metabolic syndrome, which includes the hypertension, diabetes, dyslipidemia, weight gain, or obese. And somebody started on this because of good efficacy and safety. You need to counsel them for hypertension, weight gain, and dyslipidemia and diabetes development in the future, or it may worsen the present existing things. So that's all for the things. And last but not the least for today, let's have a quick one questions last. Is it okay with you? Yes or no?
Sir, okay,
Yes,
sir.
sir.
Yes, sir.
Sir.
Yes, wonderful. 56-year-old woman present to the outpatient's clinic for a routine visit. On physical examination, a 1 centimeter nodule is palpated in her thyroid. Her physical examination is otherwise unremarkable. Her heart rate is 70, blood pressure is 126 over 82, temperature is 36 or 98 Fahrenheit. Which of the following is a poor prognostic indicator for the thyroid nodule? So this 56 years woman has a thyroid nodule of 1 centimeter. These are the vital. And what they are asking, which of the following is a poor prognostic indicator for the thyroid nodule? Being a female gender is a poor prognostic. Hoarseness is a poor prognostic. Palpitation is a poor prognostic. Patient's age of 56 years is a poor prognostic. Slow growth of nodule is a poor prognostic. Tender nodule is a poor prognostic.
Age of the patient.
I think, sir, the tender nodule.
Tender nodule. So
Hoarseness.
where you can see the tender nodule, sir, in the thyroid. Can you give me the name of the condition where you see the tender thyroid nodule?
Dequerence, thyroiditis, subacute thyroiditis.
Subacute thyroiditis. Fair enough. So tender nodule is a poor prognostic factor.
No, sir. It
Okay.
will
Sir,
resolve on
answer B, hoarseness.
risk of spreading to the vocal cords. Hoarseness might be carcinoma, anaplastic
Fair enough.
carcinoma.
Fair enough. So hoarseness would be the answer, right? Correct answer is B. Hoarseness generally implies vocal cord impairment due to tumor involvement of the recurrent laryngeal nerve. This suggests a malignant tumor that has extended beyond the thyroid and invaded the local structure. This is a poor prognostic indicator. Local invasion is particularly common in a papillary carcinoma of thyroid, the most common. Rest all have. So that's all from my side. Thank you very much, everybody, for listening me coolly and calmly today's lecture. So before I end up my session, I would like to have a quick feedback on this today's lecture. How you enjoyed? What's the learning point and related things?
Sir, I have a request.
So
Can we have
yes, please.
twice your class in a week if you can manage something? Very
Fantastic.
will be highly obliged.
Fantastic. You had given me the most difficult homework, but I manage. I do my level best, sir. I'm working hard. You can see for many times. I mean, I never miss my class.
Yeah, me too.
I
If
try.
we have a twice in a week your class, that would be great for us. Even if it will be midnight, we will be available.
I'll do my best. I'll take a sincere note of you, sir.
Thank you, sir.
Yes. Anything else? Any other comment? Dr. Anjana, you joined first time, I guess.
Yes, sir.
Hematology.
Your class was really nice. It's just that I am out of touch with the topics that I can answer, but you explained things really well and it instigated an interest in me so that I can refresh my topics and all. You did
Wonderful.
very well, sir. It was really nice.
Wonderful. You will enjoy Doctor 100% every Sunday. Don't worry. Not just Sunday.
Yes,
All
sir.
speakers are brilliant, but they are taking in the different time slot. Yes.
Okay.
Anyone else? Dr. Dilakshi, Dan Dennis, how was your experience? Yes.
As always, sir, it was great lecture.
Great. No problem. Anyone else? Last? Any comment? You also can give me the topics as well, what you want to prepare. See, it's very difficult for me to, get a request. So I go by my experience, what they ask in the exam.
Sir, we want to
So
learn asthma from you.
fair enough. So we'll try to catch up a couple of MCQ so we can adapt this my next time. Yes, Dr. Snigdha, how was your experience?
Yes, sir, it was very good, fantastic class.
Great, wonderful. So you clarify your concept, isn't it? The way we are doing the exercise here, you need to prepare, right? So that
Yes, sir.
makes more clear, crystal clear picture how you diagnose, how you treat, what's the related here and there. It's not just the mug up the answer. You understand? It won't help much, right? But if you
Yes, sir.
understand the topic, overall things, right? And we have same hundreds of videos on YouTube. So I strongly recommend you see at least one video a day. Even if you're doing, then there are hundreds of questions will be answered well, right? The same lecture will be uploaded very soon on the website. But like same, those who missed, those joined first time, don't know, right? So you go or drop me a message. I'll share you the YouTube link. You can join. You just medical MCQ for all YouTube it will pop up. If you don't get it, drop me a message. My number is this. This is permanent number on the bottom, right? So 9825578080. So this is my number. That's it. Please explain sir statistic and logical points asked in the exam. Usually they don't ask now, but still I'll try to make it video on it. MCQs on it. Fair enough. Okay. So thank you very much once again all for joining and listening. Right. Keep in touch and do your best. Keep all the points in mind. Those who have, joined the late. I have given you one slide, right? Why we cannot able to crack the exam. So this is the high yield slide, I think so. Just concentrate on this slide. What you can see on your screen. Whatever the points you have it, whatever the lacking, you do it sincerely. I can guarantee you 100 pass. 100%, not 99. But you need to commit yourself. Little increase the commitment. Right. So thank you very much and stay tuned. Enjoy your
One
Sunday.
more question,
Thank
sir.
you. Thank you very much, sir. Thank you.